All right. Good morning, everybody. Welcome to our first in our fall series of our RFK Compass Live sessions. My name is Sansia Dali. I am the Senior Vice President of Strategic Partnerships and Investor Engagement at RFK Human Rights. And I am thrilled to welcome this stellar group of speakers joining us today for a discussion on healthcare investing, particularly in light of all that we are seeing happening with the impact of the COVID-19 pandemic. We're pleased to have Nancy Taylor navigating this conversation with us. We have about an hour 15 minutes, but we're gonna go with the flow of the discussion. There is a Q&A feature in the Zoom chat. If you are compelled to ask a question, please don't hesitate. You can submit those questions through chat and we'll make sure that the panelists see those. This is a very fluid conversation that we want to have today. So feel free to chime in. We're amongst friends. As we all know, sort of the healthcare industry is a very diversified one. It's one that's been thriving quite a bit in certain aspects, both pre-COVID and certainly currently during COVID. So we're super excited to have this conversation with two funds and a CIO joining us today. But allow me to just introduce Nancy Taylor. She is the co-chair of the Healthcare and FDA practice at Greenberg Traurig, where she focuses quite a bit on providers, plans, employers, private equity firms, and FDA regulated companies. She advises clients across the broad spectrum of these issues related to healthcare transactions, health and FDA regulatory policies and compliance, and certainly responding to any congressional and administration investigations and audits. I can't think of someone better able to help guide us through this conversation because Nancy has had such a wealth of experience in the healthcare industry for a couple of decades. For 10 years, she served as a health policy director for a Senate committee and worked on a number of significant health and FDA laws. She was also the CEO of a startup medical device company. So, you know, a lot of wealth of experience that Nancy brings to helping us navigating this interesting and very pertinent discussion this morning. We're thrilled to have you, Nancy, thrilled to have our panelists. I'll turn things over to you so we can dive right in. So thank you, Nancy. Thanks to our panelists and over to you now. Nancy, you're on mute.
I appreciate, thank you for that introduction, and I appreciate the opportunity to help facilitate this discussion in such a difficult time in our country where we're all facing a pandemic and the impact on some enormous disparities that we have in the delivery of care with certain types of issues we'll discuss today. So let me start with introducing our panel, and we look forward to hearing learning your questions as we go through this. Charles Barati is with us today he's the Managing Director at Health Catalyst Capital. Scott Pittman, thank you, Scott, for joining us, the Senior VP and CIO at Mount Sinai Medical Center, right at the heart of some of the key issues we'll be talking about today. And John DiGiovanni, investment partner at Arsenal Capital. So let's start right away with some questions regarding the COVID-19 crisis. And what have you seen with regard to the changes and what are the challenges? Scott, you may want to start to discuss not only the investment portfolio at Mount Sinai, but what is occurring at your hospital system?
Sure. In fact, while we're talking today, we may be reminded with some sirens in the background I had it on a mute a second ago as some ambulances are going by. So yeah, definitely reminded that healthcare is a 24/7 service and business. Yeah, I'd say obviously the last 6-7 months have been impactful for everyone. The first 3 or 4 months of this for us was just really, really intense. I'll start maybe from the investment perspective. Our investment office does support, primarily it's for our endowment and long-term pool of capital. But we do advise and support a lot of other pools of assets, whether it's employee benefits on the DB and DC side, or insurance and reinsurance for other entities that have ties to Mount Sinai. We have someone in our office that's part of the Greater New York Hospital Association, their investment committee. So there's just a lot of ties within Sinai to a lot of other healthcare pools and other healthcare needs. And when you have an event like COVID present, everything kind of needs attention at once, and everyone needs communication at once. And from the investment perspective, you were trying to make sure that one, the organizational needs are being met, and there's questions that come up around what's liquidity, how much liquidity do we need, how do you forecast budgets with what's happening. There's the real time back in March and April. Even our investment office was hands-on in making sure we were trying to get all the PPE equipment we could for our frontline workers. And how are we using our networks and how are we using our ties to try to secure the supplies that we needed for our employees. That was a real thing that was going on in the investment office even then. And then just purely from the GP relationships, making sure that your managers, what's their experience, what's their firm stability, underlying companies and those investments, how those are behaving, the opportunity set is changing, how are you on a portfolio level reacting, whether that is liquidating or making new investments, but how are you making change in the environment, which is requiring change. So there's a lot of layers, I guess, is maybe the high level summary of this. From organizational needs to communication needs, fiduciary responsibility needs, GP relationship, and then just changes to the portfolio. So yeah, I can pause there, but there was a lot of movement and activity and change occurring through all those different layers, and still today. But thankfully, I think that pace and that intensity, although it remains, is not quite that same level of intensity as the early months.
Charles and John, do you want to comment, and especially about impact on your portfolio companies?
Go, John, after you.
Sure. Thanks, Nancy. And just want to say thank you for including me in this event. It's an impactful and conscientious organization to be affiliated with, so thank you. Yeah, so I'm a partner with Arsenal, as Nancy mentioned, and Arsenal's been around for about 20 years. We just raised our 5th fund last year, which is a $2.4 billion fund. And we invest into specialty chemicals, specialty industrials is about half of what we do, and then healthcare, which is where I focus. And I agree with a lot of what Scott said. This has been a trying time, I think, for all of us. And it's been tough in terms of portfolio management, and as we think about new investment opportunities, and there's just been a lot of disruption. I think it's been very difficult organizationally as well. It's been a mental health challenge. It's been a social justice challenge for society, and I think for us, we've had a lot on our mind and a lot to deal with, and we're trying to set ourselves apart and kind of differentiate and use this time to conduct ourselves as change agents to the extent that we can. So I'd say, early on, this was a kind of defense for us, in March and April and into May. So our portfolio company, definitely had our share of challenges. Although we sort of pride ourselves as a firm philosophically on building thematic expertise and employing full-time operating partners. And I think both of those things really helped us out and served us well. So we do spend typically about 6 to 12 months on an investment theme before we invest into a target in that space. And so we're very thoughtful about sort of the secular trends and key macro KPIs that impact the industrial environment, and then on the healthcare side. So we like to think that we pick themes that will be lasting and sustainable, even in an anomalous environment. And then we do take what we call a company building approach, so just a very hands-on, proactive approach to the operations of the companies that we invest in. Try not to be prescriptive and forceful with management teams, but we spend the time on the theme. We kind of have a blueprint, and we like to invest in the companies that may be aligned with how we think about a market and think about some growth opportunities. And we have our full-time operating partners, sort of driving a lot of that change and evolution within our companies. And so because we had a lot of that, I think, strong operational scaffolding in place, we were able to manage through pretty effectively. I mean, look, we had challenges. It was a mixed bag across our portfolio. We needed to ensure the solvency and strength of our portfolio companies, and that required a lot of support and time and attention, and in some cases investment. But we feel like our management teams performed exceedingly well throughout the crisis. One of our CEOs likes to say, "You should never waste a good crisis," which I think is a phrase many of us have heard, and it's true. I mean, we tried to use the time to repurpose and evolve some of our companies in some ways, and really position themselves for future growth. And so we're kind of beginning to play offense now. We feel like kind of stabilized the portfolio. We have made a platform acquisition during COVID into a UK public company that we took private called Telehealth, which is a real world evidence and medical affairs business focused on the pharma services space. And we've made 6 add-on acquisitions during this time. So the strength and liquidity within our portfolio has been kind of a competitive advantage as you think about others who have struggled during this time. And I would just say internally, it's been a very introspective time for us. I know we'll talk more about how our firm has oriented ourselves, how we're thinking about, social justice and some of the challenges that we've all experienced out in the market. And I think it's been a very powerful experience for us. We are taking the time and sort of making space internally to talk about some of the issues that, we're all seeing out there in the market, and thinking about our purpose as a firm, how that permeates, how that influences and connects with our portfolio companies as well as other external stakeholders. So we like to think that we're adapting and kind of learning more every day and looking ahead.
Thanks, John. Charles, what about your
Great.
fund?
Yeah, thank you. Thanks to the RFK team and the sponsors, especially Greenberg Trug. So thank you, Nancy. Health Catalyst Capital was formed on the heels of the passage of the HITECH Act, which mandated adoption of electronic medical records and helped usher healthcare off of largely a paper-based industry to now being more digitized, although a lot of that digitization was simply paving over cow paths of the old way of doing things. And COVID has been a real accelerant of the adoption of the new way of doing things, telehealth and other technologies that are achieving both greater access to care and many social objectives, as well as delivering more productivity across the board in healthcare. So we focus exclusively on investing in healthcare information technology or technology-enabled service companies that seek to improve the human condition and deliver better value and access to healthcare. We invest in private companies, low to mid-market growth equity, so companies that have a proven product that need our capital and our governance and expertise to help scale those businesses to reach more end markets and more customers. But I'll respond to your question in 3 different categories. Our team, our investors, or the limited partners in our fund, and our portfolio company. Our team, a shout out to them, have been working remotely since early March, and it's really brought out the best in all of us, as I'm sure it has in many of your organizations. Less travel has highlighted how unnecessary a lot of that travel really was, and more intimate time together at all hours, including weekends. And it's really brought us into each other's homes, as you are now in my home, in ways that just weren't happening before COVID. Our limited partners are in 2 categories. One is institutional investors, and the other is corporate limited partners. The institutional investors in the time of COVID have reached out quite a bit with interest in investment opportunities in healthcare IT. I think there's broad recognition that information technology in healthcare has benefited from the impacts of COVID driving demand for telehealth capabilities, remote patient monitoring capabilities, and other technologies. Our corporate limited partners, these are a combination of nonprofit or for-profit healthcare companies that seek access to innovation, what's coming around the corner that they should be excited about or worried about. And many of them have reached out with greater engagement around what's in our pipeline of new investment opportunities and how the companies in our portfolio can help enable them technologically to better serve their customers in the time of COVID. And then the third category are portfolio companies. We made 3 new investments this year. 2 of them were in behavioral health. And we are theme driven, and behavioral health is one of our core thematic areas of focus. And COVID has been a real accelerant to the adoption of technology. And so working across our portfolio of these 13 companies has really been focused on sharing best practices among them, how they are managing their remote workforces, how they're keeping up with the changing demand for the technology, the telehealth and other services that they're providing, and how strategically they may want to revisit based on the accelerated time frame of adoption relative to when they thought certain technologies would be adopted. So in short, it's been a busy time for our team, for the investors in our fund, and for our portfolio companies.
I appreciate it. So I think what I hear is a lot of technology, some providers, some different changes. What are the sectors that you think are the areas in the next 6 to 12 months that are likely to be looked at differently than they were a year or 2 ago? And if you were to think even farther ahead, where do you think those opportunities are, and in what sectors in healthcare? Scott, do you want to start again?
Sure. I maybe would say I don't know that it's that new, other than I think some of these trends, as we've talked about, have been pulled forward, and the adoption has been pulled forward, and so the telemedicine is one that's easy, I think, for everyone to point to. I had used telemedicine before COVID, but I've used it more since. And my family's used it more since. And, I've talked to people that had never used it until, the last few months. And I think people found that, most of these platforms are pretty effective. And, there's certain things that telemedicine's not going to be able to meet, but it can meet a lot of needs. And, my wife's parents live in a more rural area of the United States. And my wife had done a telemedicine visit with the doctor a couple weeks ago. And she was like, wow, my parents could have access to really good care. So I think there are things like this that, these trends that may not have been adopted as quickly, they get adopted maybe more rapidly. But it also presents challenges on, the payer side, right? Just how we integrate these technologies, how we bill for these technologies. And, we have to wrestle with, how to kind of move as quickly as some of these trends have moved. And I don't want to overplay or downplay, but, this technology super cycle, I truly believe is a real super cycle. It's kind of a lot of mini cycles over the last 30 years that have kind of built to the current one. And, I'm more of the mindset that this is more akin to the Industrial Revolution in terms of its duration, in terms of its impact. And so this is impacting all industries, and healthcare is one of those that, we recognize that there is a lot of inefficiency. There's room for lots of improvement. There's a lot of unmet needs. I mean, mental health is an area that was an unmet need before COVID. I think, the last 6 months have, been critical in, bringing that need forward. And we've also seen early adoption of new innovations, applications, and some technologies to try to help support even areas like mental health. So yeah, I'm not, going back to kind of the original question, I'm not so sure that there's anything that much, new as much as, yeah, I think we're accelerating some of these trends that were in place. And, we can also talk about the pros and cons, because there's cons in some of this too, and some of the disparities that it can create. But yes, it is exciting to see for now how technology is able to meet some of those needs. Although there's still the aspect of, I had to cancel my dentist visit a week ago because I had a work meeting that conflicted with it. And I thought, well, who's going to the dentist? And, I try to go to reschedule and I can't get in until late October, early November. So, certain services, still, are going to occur without the help of telemedicine. But, there are some, trends here that I think are having a big impact, and COVID's accelerated.
So John and Charles, what are the areas that are going to have to change? What providers, what insurers, what areas will force the change, will be forced to change after this period?
Let's start, Charles. I can. Yeah, so
Sure.
Yeah, it's a great question and important topic to discuss. I think, there's a lot of irrational trending and behavior, it feels like, in the public markets today. But just listening to Scott's feedback, you can look at, United and Humana and some of these more innovative health plan, health insurance stocks, and you can look at Teladoc and their acquisition of Livongo. You can look at some of these more innovative primary care models coming out, like One Medical and Oak Street, which filed for their IPO. And you see a lot of, I think, warranted success in some of these businesses, which is sort of representative, I think, of a lot of the trends that we'll talk about, and some of the trends that Scott mentioned. So I think for us, yeah, we're looking at maybe three key trends. One is just a shift in how healthcare is paid for. So the shift to value-based care, which has been a long time coming. But I think you've just seen a lot of success there, improving out that model in some ways for what I think is a second trend, which is just the alignment of incentives between payers and providers, and shifting to these models of capitated contracting and bundled payments, and just sort of sharing risk based on the success of outcomes, based on responsible cost management between providers and payers. And then I think third is just the adoption of technology, telehealth, virtual care, remote monitoring. And yeah, I agree with Scott. You've seen, this technology trend sort of tested, and it's succeeding in many ways. I don't think it's as simple as something like this anomaly will kind of force adoption, because I think you could look at the education system and say, man, the jury's still out on whether virtual education works, and it's causing a lot of headaches. And so I would say it's forced, the testing of telehealth in many ways in the healthcare space, and it's really worked very effectively, is what we're seeing across our portfolio, and as we think about new investment themes. So for us, it results in, on the kind of provider payer side, two primary investment themes that we're looking at. One is value-based primary care, and the other is telehealth, and they're not mutually exclusive. So we think that, primary care sits at a highly influential position at the center of care provision, really serving as a care navigator for patients. And primary care is kind of a low cost, high value add critical component of the provider ecosystem. And, it's 5% of healthcare spend, but controls 80% or so of every healthcare dollar spent. Every dollar in primary care saves you $13 in the system elsewhere in acute care, ER, business, et cetera. And we think that's because value-based primary care providers are really just helping the system, helping payers and CMS avoid some unnecessary costs, enable access to the right type of secondary care. So you could argue that some investors could be overzealous as they think about betting on value-based care and population health, right? And there have been some cautionary tales. So maybe you're looking at anticipating an unmaterialized theory, but it feels like during just this last 6-12 months, you've just seen a lot of great traction that's proving out the benefit of some of these shifts. And we feel like the wheels of progress are in motion. You've got government and bipartisan policy support for care provision and lower cost settings and improved incentive models like value-based care. And value-based care, we think about it amongst the Medicare population, was I think a third of payments for seniors 10 years ago. And it's almost 60% today across Medicare Advantage and also the ACO, the next gen, now the direct contracting kind of synthetic value-based Medicare fee-for-service models. And because it's just really working effectively. I think our research would suggest that value-based contracting, Medicare Advantage specifically, saves you about 10% of the cost on a typical geriatric patient, while Humana and others and their data would suggest it also drives better outcomes, 10 to 15% improvements across a lot of important clinical KPIs. So we're really excited about that space. There has been some private equity investment into primary care, but we're taking a thoughtful approach to that market. And then, we are spending a lot of time on telehealth. So I'll stop and I can maybe chime in later on that. But yeah.
So Charles, let me change it just a little bit. The federal government over the past few months has spent almost $200 billion and given money to the healthcare sector. What has that done to your evaluation of the market, and how has it impacted your evaluation of how things will change or not change?
Yeah, well, it's a great question, and Nancy, I want to first say I agree with everything Scott and John said. In response to your last question, which does dovetail really well into this. Scott mentioned the technology super cycle and the analog of the Industrial Revolution. It's really not an overstatement. Healthcare is about 20% of our GDP. So putting the dollar figure you quoted in context, healthcare just happens to be a very large part of our economy, and we really stand out in the world. 1 out of every $4 spent on healthcare in the world are spent here in the United States. And still we have unmet needs. We have people without health insurance, and we can debate whether we're getting good value for that money or not. So the way we think about it is not how much money is going in, because it's small relative to the scope of healthcare. The question we ask is that money being put to productive use? Are taxpayers getting good utility for those dollars and the way that they're being spent? And we see an enormous amount of opportunity to improve the human condition, deliver better value and care, and provide more access at a lower price tag than what's being spent today. And we think technology is a great enabler. We do think it's very analogous to the Industrial Revolution. And just as railroads were necessary for efficient distribution in the Industrial Revolution, sticking with Scott's analog, healthcare has gone from being 85% paper-based health records to now 85% digitized. Still some ways to go. But what this has done is really laid the railroad tracks. By moving off paper onto digital systems, we now have the distribution of the data and the ability to deliver care in a much more efficient way. It's part of how telehealth was enabled so quickly. It was there. You asked the question, Nancy, what's new? And I think it's important to note that technology is not new. The telephone existed for a long time. So why wasn't telehealth happening before? A lot of telehealth is still telephone. The video is not necessary, or could be chat. But I'll tell you what's new is awareness, and especially among regulators. There were tremendous regulatory hurdles that existed and still exist today. For example, to allow you, Nancy, to see a doctor in New Jersey if you're sitting in New York. Why? There's a lot of regulation at the state level. If you're in New York, you can't buy health insurance from New Jersey. So there are a tremendous amount of regulations that have held back progress in terms of adoption of telehealth. For a doctor to get paid, it's only fair that a doctor's paid for her time. And so talking to a patient on the telephone was not going to get a doctor paid. COVID-19 has forced more rapid deregulations, got rid of a lot of unnecessary regulation and red tape and inhibitors to patients getting access to affordable quality health care. And that's what COVID's done. It finally, after a long time into the COVID epidemic, states like New York said, okay, we will pay for that behavioral visit if it's done by telephone or video. You don't have to go there in person. And so I think that's really important to note, that the technologies existed since Alexander Graham Bell, but the regulations have held back adoption. COVID's broken through those regulatory barriers, and it's a very exciting time to be in healthcare, technology because of it. There's tremendous social good that's coming out of this awful pandemic that will persist after the pandemic, and one of them is going to be, I believe, greater access to quality, affordable healthcare, because today healthcare remains very expensive and unaffordable for many of the most vulnerable people who actually need it the most. And telehealth can be delivered at a fraction of the cost of in-person healthcare, not just the time off of work or the time away from your family who you can't leave behind to go see the doctor because he won't see you by telephone or video because you won't get paid unless you physically go there. For example, behavioral health is probably the quintessential example of the ways that technology are improving access to care and quality of care. Because in behavioral health, digital therapeutics work. The idea of an app instead of a pill, or an app instead of or with a human condition, cognitive behavioral therapy through apps to help you sleep if you have insomnia, or to help reduce stress, is a great example of taking hours of human clinician time and shrinking it down to something that can be provided with technology and people in a much more efficient way. And another great example is, as John was talking about, primary care. And United Health Group, the biggest insurance company, is also the biggest primary care company. They have the balance sheet, the access to capital to acquire primary care physician groups all over the country. This is way pre-COVID. So what COVID has done is now created an opportunity for other health insurers to afford to do what United Health Group could only afford to do because of its balance sheet. But instead of acquiring provider groups, health insurers are now making primary care available through their apps. So Pager, for example, is a New York City-based healthcare technology company co-founded by one of the co-founders of Uber. And Pager is a technology health insurers are adopting so that when you buy health insurance, the health insurance app can be used to deliver primary care via their app, video, text, or telephone. So great examples of this industrial revolution really taking place today, and examples of, Nancy, what I think is new despite the old technology that's really driving adoption.
Nancy, you're on mute.
So we have we have to talk about the difficulties that we have in our healthcare system, which are similar in our human rights issues. We've all had a lot of recent attention to systemic inequality, and we all know that COVID is impacting those who are poor and those who are minorities in our country. So please just take a moment and talk about what you are doing about this and what you think others could be doing to help it. And Scott, let me start with you again.
Wow, thanks. This is actually a huge. I mean, it's hard when you ask that question even know where to begin. Just to be completely transparent, because there are so many thoughts that hit terms from organizationally. I'm gonna touch on everything, even on the personal side. So. Sinai, let's start there. On the organization end, very thankful that Sinai has continued to be included as one of the top employers for diversity. We do have a diversity and inclusion officer. We have an office that supports the diversity and inclusion officer. We have seen over the course of the last 6 months, board members provide support from frontline workers who can't make it home, to providing places for them to stay, to providing on-site childcare services, to providing food delivery. There's been a lot of support just from the employees themselves. We've seen communications coming directly from employees to all employees, and we have 46,000 employees on issues of racism and Black Lives Matter, addressing their personal thoughts to these issues, and those issues and those comments being broadcast to all employees at Mount Sinai. So we see that from peer to peer. We've had encouragement to read and to listen to podcasts, and I read How to Be an Anti-Racist and many other things in just terms of just gaining and listening and learning even more so in this environment. So organizationally, yeah, I do think it's important to be setting the right tone and the right culture for these conversations. Within the investment office, we've continued that conversation. I'd say from our manager relationships, we have always held certain standards to our managers, and maybe just kind of a quick comment to that is we have moved to terminate relationships in the past, and not related to performance, but related to concerns of culture and other aspects. And so we do take those things seriously. We've built into our operational review with our managers improvements to ESG considerations, sexual harassment policy. We continue the conversation of diversity and inclusion with our managers. But I think one of the things that the last 6 months has helped to show me personally, and then I think more specifically with the investment office, there's definitely a level of listening and learning and awareness that has to occur, and that's always occurring. Like if you ever stop that in general, then just I don't know, don't. It's kind of hard. It's hard to be a human being and not want to continue to listen, to learn, and to gain an awareness. But I think what's helped me to see in the last 6 to 7 months is how can we be more proactive? And we've taken action, but how can we take greater action? How can we be more proactive? So specifically in the area of diversity and inclusion, if we continue to use our same sourcing and our same network, which is great. We have great sourcing, we have great network. But we need alternatives. We need to bring in less traditional sourcing, and we need to find those resources to broaden those opportunities that we're seeing. And so as an office, we've had those conversations of where can we find kind of alternative pipelines of sourcing, and how can this help influence outcomes that are supportive of the portfolio, and more specifically, how can we team members act as a resource and help support whether it's peer or industry initiatives, or more specifically internships and other types of opportunities. How can we help support things that can further with what we can control these important topics. And then stepping back a little bit just to this kind of conversation of inequality and how that kind of fits within this technology access. My daughter, actually, I'll mention this as just kind of a side story. She was at one of the local elementary, she's a senior in high school this year, but she was one of the local elementary schools with an organization she works for, handing out laptops for elementary students that needed them for the school for technology access. And over the course of COVID had been a mentor and kind of a student tutor for students that didn't maybe have access to the same resources. And it's just through her eyes and through kind of seeing just these remote learning disparities, it's just so very real. Technology is great, but it's great if you have it, and it works well, but it works well if you have good Wi-Fi and bandwidth. And you can really use it effectively if you have people around you that help you understand how to use it effectively. So there are these things in terms of training and access that if you don't provide that, is this going to further some of these aspects of inequality?
So John and Charles, we got a question that I think you can both maybe respond to, that goes to how do we bridge the access divide for low-income and minority communities who might not have the digital ability to do so? Are there opportunities for health tech investments targeting these communities? It's one of the challenges to you. So Charles, I'll let you start this time on this one as part of this effort.
Sure. Well, it's an excellent question. And, again, Health Catalyst Capital puts our entire, investment portfolio and our time, our human capital, into backing companies that seek to improve the human condition and deliver better value. And that means better access to care. And a lot of progress has been made. It's been accelerated by COVID, but we have a very long way to go. And what is exciting is the states are already spending the money. The federal government is already spending the money. It's just not being spent in the most efficient way. And I think technology can play a really important role. And I'm incredibly excited that not only has this COVID pandemic driven attention to some of the barriers to adoption of the technology, barriers to access to care, but it's also brought attention to, thanks to the Black Lives Matter movement and others, the social injustices, and how healthcare is a really poignant example of the social injustices if you look at where COVID hit the hardest. And it's not just COVID. You step back, you realize those are the same communities not getting the best behavioral care. Those are the same communities not getting the best primary care. They're the same communities not getting the best education. And again, there's a lot that's been done. I think it starts with awareness, since the money is already there. It's just not being spent optimally. And again, we think technology can play an important role. And I think the best example of a response to that question is telehealth. According to Pew Research, of the vast majority of Americans now have a cell phone. 96% now own a cell phone of some kind. And the share of Americans that own a smartphone is up 81% from just 35% when Pew started this survey in 2011. So it's a huge growth. What does that mean? That means that healthcare can now be delivered to many of these communities because people have mobile phones, and many of them are smartphones. And so whether it's phone, text, or video, enabling providers to come into these communities and see more people remotely for many of the things that can be done remotely. Now, granted, most of healthcare, I'm sure Scott would tell us at Sinai, most of healthcare can't be done via telehealth, and that's very true. But there's a lot that can be done via telehealth. I read recently that one of the states is now allowing pharmacists to conduct COVID tests. Well, why couldn't they conduct COVID tests before? They're perfectly well trained to do that. So is an optometrist. And so regulations have been a barrier to adoption, a barrier to allowing trained clinicians to operate at the top of their license. And we think, telehealth into these communities that need it most, on the cell phones that they already possess, or in low-cost kiosks that can be put up in local drugstores or in local clinics or in other locations to provide more access to affordable care. And again, the money is being spent, and the technology exists. It just takes a little bit of, oomph on the part of the local governments to enable it.
John, you want to make a quick comment about the disparities and how we can get better care and better access in rural and low-income communities and those who are disadvantaged right now in our healthcare system?
Yeah, no, I think there's a lot of work to be done. I know in some conversations that we've had with our healthcare advisory board internally at Arsenal, we've heard about just a significant increase in telehealth adoption from low single-digit percentages at a lot of large health systems like Mass General, up to 70-80% during COVID, and I think things are normalizing a bit, but it's still an appreciable percentage of the care being provided in a lot of systems. And I think the pandemic has transformed the landscape of ambulatory care with this rapid shift, and well-resourced hospitals have been able to make this transition really effectively, but community health centers have really struggled with it, and I think community health centers serve something like 30 million low-income and uninsured, often patients in rural and underserved urban areas. So, that's definitely a challenge. There's a challenge with a lack of, sufficient reimbursement and uncertainty around how reimbursement is going to look coming out of COVID. And once the shine wears off a bit, there's definitely a lack of, funding for equipment, oftentimes lack of training for the usage of telehealth and a hybrid telehealth and physical care provision model, and just how that should work. So I think there's policy support that needs to be provided off the back of the CARES Act going forward. I think we as investors can think about in the healthcare space how we can include telehealth and virtual care and some of this technology into some of the businesses we provide, especially in the care provision setting, to just advance utilization and provide access to some communities who might not otherwise have it. We have a business called Hope Bridge in our portfolio, which is a large center-based autism therapy company. They've got 50 centers in the US, and they serve about 2,000, 2,500 patients, autistic children, and They have done a great job. We've tried to support in any way that we could, but I would say the management team there has done a great job of adopting telehealth. Really didn't have it in place prior to March of this year, and have adopted telehealth, provided virtual care solutions for over 1,000 children over the past 3-6 months, and have had a lot of success. And they largely serve a Medicaid population, so they have actually been able to access more autistic children who need help than they could have otherwise, because of by virtue of telehealth and the access you can provide to communities where Hope Ridge might not have a center that's in an accessible proximity to those patients and those families. So you're sort of seeing some of the opportunity that is being presented here, and you've had reimbursement unlocked for telehealth and ABA therapy that really didn't exist before. And that has enabled us as a business and care provider to provide that service in a way that's sustainable for the company. And hopefully that persists. But I think, policy and discussions amongst policymakers and the government, bipartisan discussions with, investors and business owners and all key stakeholders, health plans and providers in the healthcare space, are going to be really critical for us to continue to make progress.
So let's make sure I'm on. So let's have a little interaction about the vaccine. Let's talk among each other about how it should be rolled out. How can we ensure there's no disparities, as there may have been in testing and otherwise? And who should get the vaccine first? I think, Scott, many would say it should be healthcare professionals. But should we be getting it to high-risk populations first, like nursing homes and minority areas? What do you think? Let's try to get some discussion among us. Scott, yeah, you start maybe, and let's just have a discussion about it.
And is this what I'd like to see versus what may happen, or?
No, let's say you can say what should happen.
Yeah, no, I think as you're having this made accessible, in a perfect world, you're identifying those most at risk, and it's not just most at risk in the United States. It's thinking a little bit more globally, and where are there countries that may be at greater risk, and specifically within the United States. These inequalities that we look at, especially among Black and Latinos, I mean, the disparities are quite large. And if you look at those during this period of COVID that could work from home versus those that couldn't because they weren't provided that opportunity, there are certain segments of our society that are much more at risk, and don't have that opportunity to try to protect themselves in the same way if they so choose. So yes, I think if you can identify whether it's by age, whether it is by populations in society, those at greater risk, frontline workers from as you mentioned, a job category, and provide them access first and try to meet those needs before rolling it out more broadly, I think would definitely be the best approach. I do think we always in all of this have to be hopeful. In some ways, we've used this word policy several times now, and so many policies we recognize as being racist policies or poor policies, and have led to these inequalities. And I think the other side of it is knowing that some of these policies have created some of this disparity. Hopefully we can solve some of this disparity with good policies. And thankful for those like John Lewis, we're reminded of, who have given and dedicated their lives to driving policy change. I think we have to be a part of this process as much as we can within our own control and our own environment, to be aware of these policies, to support policy change, and to figure out how we can then better address the right policies going forward. So when you talk about how a vaccine gets rolled out, I'm hopeful that then that we can address some of these groups and areas that need it most before it's just kind of broadly given to whoever has access.
So what will be the benefit of having a vaccine, Charles? Why? What will it do to the healthcare system, and what will it do to the issues we're discussing today?
Nancy, I think it's really important that you're asking this question, and I hope policymakers are working on this right now in anticipation of a vaccine becoming available. I hope that your question is asked by politicians, but answered by medical professionals and scientists who can help, advise on what the best thing is to do for the country. I think therapies and vaccines are essential for us to all get back to normal, and not everyone will be able to get it at the same time. There's still questions about the safety of a vaccine. Many people don't vaccinate their children today for things that like measles and other things that everyone should be vaccinated for. So I think a lot of work needs to be done, and I hope it is being done to be able to respond to your question. I think if safety is a concern, then there'll be two sides to the coin on whether to deliver it to the most vulnerable populations first. Will some of those populations believe they're being used as low-cost guinea pigs to study and see how they did with the vaccine before I get it? And so these are, I think it's going to create an opportunity for a lot of social discourse. And so the sooner people who are qualified to answer your question begin working on the responses to this question and begins that debate, a very transparent public debate, I think the better. And I'm glad you asked it, because we're not hearing it asked as much publicly as I think it should be.
John, do you agree?
I agree, and I think Scott and Charles made great comments. I'm aligned, and I don't think I have much to add.
So just a final quiz, just quick round robin. Where will we be in 24 months in the healthcare sector? We've already heard about telehealth and greater adoption and likely reduction by the insurance companies in payment for those visits. So then where will the healthcare system be? Will it be run by a lot of insurance companies? Will there be more openness and treatments for those who have economic disparity, or where will we be in 24 months? Charles, real quick round.
Yeah, well, I think what we do know is that healthcare is accelerating its adoption of technology. We think that's going to lead to more affordable, higher quality healthcare. And so healthcare spending has only grown each year, and some years faster than others, since my lifetime, and since which is contemporaneous with the formation of Medicare. And I think we'll see signs over the next 24 months of the cost of healthcare, access to healthcare, actually going down, because telehealth can take a 20-minute doctor visit and shrink it to 5 minutes. So I think we'll see evidence that technology can deliver more care, better access, better care at a lower cost. And that'll be the dawn of a really exciting few decades in the industry.
Good. Scott?
Yeah, I think the trends toward value-based care, obviously seeing that continue. From I think a hospital system perspective, there is a revisiting, which I'm sure with a lot of businesses, of just real estate space, and for capital expenditures, what's the best use? I mean, for a healthcare system, projects can be extremely expensive, and so you have to be very careful where you're putting that capital towards. And so kind of evaluating, what adoption of technology, money towards that may be better spent than, building, more space, but still balancing, because obviously you do need beds and there's needs that need to be met. But I think an evaluation of the spending needs in healthcare for a health system of, technology versus kind of the brick and mortar, that's going to look a little bit different maybe in 24 months.
Yeah, and I think great points. I would just add, increase in preventative care, maybe I think associated with the adoption of telehealth and the shift to value-based care, but hopefully, more models like Medicare Advantage and managed Medicaid that are focused on driving improved outcomes and focused on, cost efficiency in the system, which, as Charles has mentioned, definitely is accelerated by the adoption of telehealth, which provides better access and a more cost-efficient approach, oftentimes, to the provision of care. And so, we feel like those are very important trends in the space, and with not just virtual portals to provide care or the telephone, but remote monitoring and patient engagement, you can collect a lot of very important patient data early, which would enable you as a provider to take a more proactive approach to patients' health. And as you're thinking about a provider that's taking risk, then you really want to focus on the social determinants of health and population health, and that's enabled certainly by technology, but even in those Medicaid populations where you should be thinking about inequality, you should be thinking about transportation and nutrition and access to a lot of things that are table stakes to many of us, fortunately. How can you assist with those issues and think about healthcare much more broadly maybe than the traditional sense, so that you can really drive improved outcomes? I mean, it works for the providers and payers, and it's beneficial even to the bottom line, but it is certainly more impactful to the patient. So hope to see more of that.
Thank you. Thank you very much for the opportunity, and thanks for your input. I'll turn it back to you.
Sure. Thanks, Nancy. Thanks, everyone. We just wanted to, I know we had a couple minutes, and we've allowed all participants the ability to speak if they wish to. So just wanted to throw out the opportunity if there are any additional questions that you might want to ask. I see a hand raised somewhere. Give me 1 second. Steve Tremetier. Steve, please go ahead.
Yeah, can you hear me?
Yes, we're hearing you very
okay,
well.
Great.
Steve, just let us know who you are and the organization you represent.
Sure. Steve Tremetier. I'm the Chief Development Officer for Brevation. And great session. I just had a quick question because I know we're short on time. You've spoken a lot about population health and social determinants. Can you talk about any circumstances where you've actually made investments into those areas?
Probably not enough time on this call. I'm happy to follow up afterwards. And the investments we made are all on our website, healthcatalyst.capital.com. But we have a portfolio of 13 companies that are focused on improving access and quality and cost of care. And Sibley is a great example of one delivering behavioral care via text and navigation via text. Pager is one that's enabling telehealth. Simplify is enabling telehealth for providers. And all these technologies are improving access, which is able to help support addressing the social determinants of care. But it's really core to what we do. And again, we think a lot more can be done.
Yeah, I think, Steve, it's a very good question. Just because I think maybe as you're suggesting, or the way I'm interpreting the question, there has been a misalignment maybe historically between investors' willingness to sort of place a bet on social determinants beyond just the discussion of the buzzword or around population health. I think, because there has been a struggle with the proximate value for providers, for constituents in the system of adopting more population health technology or solutions versus the fee-for-service model, which doesn't necessarily portend investment often into population health infrastructure. But we're seeing more of it. Yeah, I wouldn't get into detail on this call, but we have population health tools within a number of our companies, like the autism therapy business I mentioned. And I would tell you the importance of population health and social determinants technology that's effectively integrated with the EHR and serves as a very important component just of coordinated care provision within a primary care business is top 2, top 3 characteristic that we need to see and look to build upon in any investment that we make in that provider market.
I'll throw in a comment in this too. one interesting observation from our healthcare system, our executive CFO is going to be retiring towards the end of the year, and he's been a tremendous positive impact on Mount Sinai for a long time. But the new executive CFO stepping in is actually, the background and experience is all population health. So you can see that the health system continues to put a big emphasis on the experience of someone that's going to be sitting in the executive CFO position, of having that direct relationship to population health. And while the system has been investing in technologies, we've also been doing even more hands-on applications, so that if there are groups of high-risk patients, there is a group within Sinai that specifically will call, make sure that you're taking your medications, help you coordinate your appointments. A lot of visits may go dropped just because you have a lot of doctor's visits that get strung out across 1 to 2 weeks, and it's hard to get them all. So, but if you can coordinate all the visits in 1 to 2 days, and so just simple things like that help to organize for high-risk patients their needs, and also support with the technology, and the system's still very much committed to it long term.
Excellent, excellent. Thank you so much. Thanks to each of you for partnering with us on this. We thoroughly enjoyed this conversation. The healthcare industry and the topic of healthcare investing has increasingly become one of priority within the work that we do within Compass. And as you all know, the ethos and the mission of the work we do is to highlight where and how investors can better advance through their investment decision-making process, equity for all. And so, this topic is very, very much pertinent to that broad mission of our organization's work. Stay tuned for more on this to come. 2 dates I wanted to highlight for everyone on the call. October 13th, we'll be hosting a mini summit, or Compass Investor mini summit. And so we'll be releasing more details about that in the coming weeks. And then on December 10th, we'll be hosting our annual Ripple of Hope Gala, where we'll be honoring 5 stellar leaders in our community, including Dr. Anthony Fauci, Colin Kaepernick, and a number of other leaders. And we'd love to have you supporting us and joining us in that effort. So happy to share that information. It's all on our website as well. In the meantime, continue to take care, continue to stay healthy and safe. And we thank you for continuing to support us. And thanks to you, Nancy, Scott, Charles, and John, for a really great conversation this morning. Thank you so much, and have a great day, everyone.
Thank you.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Thank you.